Welcome to TEDMED Conversations, where medicine, science, and the human experience meet the ideas shaping our future. In this episode, we're diving into a question many families and clinicians are asking. What if pediatric care were designed around relationships, not volume? Your host is Theresa Santoro, a healthcare leader and strategist with deep experience in care delivery models that put people first. As CEO of RVNA, Theresa has spent her career reimagining how care can be more humane, more sustainable, and more closely aligned with the needs of both patients and providers. She's joined by Dr. Lauren Hughes, a pediatrician and the founder of Bloom Pediatrics, a direct primary care practice built on a simple but radical premise: fewer patients, more time, and care that extends beyond the exam room. By stepping outside traditional insurance-based models, Dr. Hughes is experimenting with a new way of delivering pediatric care, one that emphasizes access, trust, and long-term health. Together, Theresa and Dr. Hughes explore the promise and trade-offs of direct primary care for pediatrics, from how it changes the doctor-family relationship to what it reveals about the pressures facing clinicians today, to the bigger question of how we might redesign care systems to better serve children and the people who care for them. This is a conversation about innovation, courage, and what it really means to put kids and caregivers at the center of healthcare. This is TEDMED Conversations.
Hello, Dr. Hughes, and welcome to TEDMED Conversations.
Thank you so much for having me.
Absolutely. So, Dr. Hughes, before we get into the nuts and bolts of direct primary care, I'd love to start with your story. What was the spark for you? What made you think, this is the kind of pediatric practice I want to build? And ultimately, what led you to create Bloom Pediatrics?
So it actually kind of started back in childhood. So my dad is a small town family medicine doctor. He owned his practice. It was a traditional practice, but it was a traditional practice what it was in like the 80s and 90s, and people would pay him in like tomatoes and corn and things like
Right.
that. And, a lot of farmers and a lot of things. So I remember I helped him put in stitches for the first time when I was like 6, and it was on my kitchen
Wow.
table. I kind of grew up with that was my idea of what medicine was, where you just took care of people. And that was it. We'd be out at dinner and people would come up and they're like, "Hey doc, I got this limp." And he's like, "Yeah, call the office. I'll get you in Monday morning." Like that sort of a thing. Get to college, get to med school, and finally got to residency. And when I was in residency was my first time truly practicing in what the healthcare system is now. And there was one very specific incident that happened in residency that I was like, I can't practice this way. I had this one patient that was very well known to me. She was she had asthma. They struggled with access to care, affordability of medication. And so she came in frequently for exacerbations. And I saw her before lunch. I gave her a treatment. I said, "Hey, run downstairs, get something to eat, get like an hour or something, come back up. And so we can make sure the medication worked, that you're good to go. I want to make sure that you're safe before I send you home." And when she came back up, saw her again, she was good, was able to send her home. I got in trouble for that because you can't bill twice in the same day.
Right.
For a patient. The exact words said to me was, "You will never keep the lights on if you practice medicine this way." And I sat with it and I was like, but I didn't do anything wrong. I struggled so much with how am I in the wrong here? And I couldn't fathom that would be how I practice the rest of my life, of either send her home and fingers crossed that she does okay, or send her to the ER where her mom is now going to miss an entire evening of work, or they're not going to be able to be seen or be exposed to who knows what, be stuck with this bill. And so I remember thinking, like, I've got to figure out what I can do. And I was doing my night rotation later on and was scrolling through Facebook, and a local physician talked about her practice. And so I started Googling her practice, and she does direct primary care. And I started reading about it, and I was like, this is it. This is how I can, with what my childhood expectation of what healthcare was, and now what I am seeing what healthcare is now, and they are not the same. Direct primary care was the way that I could practice medicine old school without the constraints and the issues and the moral failures that I felt in the current system. And so I
Love it.
was I crossed my fingers, told my husband, I said, "Hey, you know how I've never made money? I'm going to continue not doing that. And we're going to also take out a loan." And the day after I graduated residency with 4-month-old twins and a brand new 3-year-old, started Bloom Pediatrics.
Wow, what a great story. I just love how it began so organically and with the example you used with your dad. What a beautiful, beautiful story. Many listeners have heard the term direct primary care or DPC, but may not fully understand what it truly means in practice. Could you walk us through what DPC is and, just as importantly, what it's not? I wonder if some people are thinking, how does this differ from traditional concierge medicine? What is it and what isn't it?
The phrase that we use in DPC is, if you've seen one DPC practice, you've seen one DPC practice. And they are all incredibly different. And my favorite part is that I get to make it exactly what I want and however I want it to be. It's not concierge. It feels similar in terms of the contact and the accessibility you have to your doctor. Concierge is typically where they charge a fee for the access, but then they also bill your insurance. And direct primary care is, we have nothing to do with insurance at all. It also is much more affordable than I think most people realize. It's usually $70 to $100 a month. And most people are like assuming it's in the realm of 1,000. And so it's much more affordable than people realize. And then compared to like a traditional practice where you have to pay a copay or whatever, we don't do any of that. So in my practice, how it works is our patients pay a monthly fee, and they have access to us at all times. They can text us, call us, send us pictures. Right before this, I was getting a picture of, "Hey, this rash popped up. Do I need to be worried? What can I give?" Was able to answer it in just a couple minutes. And so you're able to just handle things very quickly.
Hmm.
Patients can have as many visits in a month as they want, and it doesn't cost them anything additional.
That's really innovative and is impressive that you have, carved out this niche. I think one theme that comes up when speaking with clinicians who have pursued independent or innovative care models is the gap between medical training and the realities of running a practice. We know that physicians spend years, right, mastering diagnosis and treatment, yet receive minimal formal training on operations and how to run the business, finances, revenue models. And these are the very skills that can determine, right, how much autonomy they have in shaping their patient care. So for me, in my practice, nonprofit home health, community health, one of the challenges and the joys of running a mission driven organization is balancing that financial sustainability with the desire to provide care that truly meets the community need. In our case, it's often unreimbursed care or free vaccines or wraparound services. I imagine you must face very similar opportunities and challenges at Bloom. How has running the business side of your practice allowed you to provide those kind of services? And why do you think it's important that physicians need to learn it?
Whenever you work for a company, you need to know how it works at every step. And that's why I really enjoyed like starting my practice, because I know everything from how to get the toilet seat fixed all the way up to how to get the billing correct, right? And so I think it's important to know where you work, how things work. And with the business side of it, we get no training, none. I had no idea how to start a business. I had no idea how to do any of this, but we are taught how to seek out resources and find help. And that was something that I was able to utilize and talk to other people and create a network and be able to understand how to start a business. How can I balance having a financially successful business with doing philanthropic things? And that's, again, part of like, I get to do whatever I want. So, whenever the shutdown happened, I stopped billing anyone that was affected. I do a free vaccine clinic in the fall for flu, COVID, and RSV for anyone that can drive to our office. I spend the entire weekend giving those vaccines as well as the weeks preparing for it. One of my partners does free physicals and lead screening and immunizations at Head Start, which is the local government assisted funding for preschools. And so we are able to do whatever it is that we feel drawn to do. And so whenever we have a patient that has a need, if they lose a job, if something goes on, they just talk to us and we are like, okay, yeah, until you're back on your feet, we'll figure it out. I get the autonomy to do that. Whereas if I was in a traditional practice and someone lost their insurance, okay, bye. Good
Right.
luck.
Yeah. That kind of leads me to my second question. I just love how creative you've been. You've sort of looked out of the lines of, this is what reimbursement, this is what the insurance covers, and this is all we can do. With that in mind, how do you think the lack of business and operational training in medical education affects sort of mainstream? Again, you've been very creative in how you've, looked very holistically and comprehensively at people's needs. But mainstream, you just sort of, you don't go out of those lines. The lack of that education, how has that affected the general population or physicians at large?
So I think whenever you're in a traditional practice, you do have a lot of support, which is necessary with the amount of patients that you see, right? But what you don't see then is like, okay, well, this patient, I referred over to this clinic for PT, but they no longer take their insurance, or this referral specialist is no longer taking that insurance, or this medication they can text me and say, the one you sent in, my PBM no longer calls tier 1. And so now it's a $90 copay for my medication. And there is so much whenever they leave your office that in a traditional practice, you don't know. You don't realize that these medications, patients aren't filling them because they can't afford them because their pharmacy plan changed. And whenever you are the only one providing that care, I know all of it. And so my patients are able to tell me, hey, this inhaler is no longer covered. We have to figure out what inhaler we can get you. And there's so much of that business side of it. I also get contacted for every prior auth. And so I am very aware of the struggles that go with those prior auths because I am the one handling it from the first denial. So I think it gives me a very good perspective. In a traditional practice, I wouldn't have that because I have the support staff, which it does kind of give you a bit of a tunnel vision of like, no, I prescribe the medication and the patient gets it. But I also understand that you can't do all of the things in a practice that sees 40 patients a day.
Yeah, I think that's well described, the tunnel vision. I mean, that is sort of the standard, right? If you can't think creatively and look to meet the needs, you do have that tunnel vision. You're absolutely right. I'm just wondering, as you began to understand the business side of practice through all of this hands-on experience, and it sounds like you're extremely hands-on, on the back end of running the business. Was there anything that surprised you the most that you couldn't see
Yeah.
coming?
Ha! So, the thing that surprised me most was how inexpensive things are without insurance.
Wow.
I was mind blown at the cost of labs, at the cost of imaging, at the cost of medication without insurance. In Kansas, as a physician, you can both prescribe and dispense medication. And so we keep like amoxicillin on hand, and a 100 ml bottle from the wholesaler is $2. A CBC is $2. A lead screen is $12. A vitamin D level is $13. A chest x-ray with the read is $30. It really frustrated and infuriated me to realize that these bills that we are getting for labs and images and stuff whenever we utilize insurance, because if you have a contract with an insurance company, you are obligated to bill them. And how much cheaper it is without them. And it just was so frustrating for me to like to fully comprehend how expensive insurance has made primary care. Now, insurance for the serious stuff, the hospitalizations, the ER visits, like, yes, that's when it's necessary. But in the outpatient setting, getting like a vitamin D and a thyroid panel is less than $20 for my patient.
That's
But if
amazing.
I built their insurance, it would be hundreds. And in addition, like if I get, if we get an MRI on a patient, it's $250 to $400. And without insurance, there is no prior authorization hurdle to overcome. And so it doesn't delay care. We get care done faster. Whenever I first got our contracts for our imaging and labs, my jaw was on the floor for many days.
Wow, it sounds that that is incredibly eye-opening. Thinking about any listener who might be across the country who would like to model something similar that you're doing in Kansas City, what skills or knowledge areas do you think are essential for any clinician listening now who would like to create a more flexible, mission-driven care model that you have done?
You have to be willing to run a business. It's not for everyone because not every doctor wants to be a business owner. And you have to want to be a business owner. You have to want to deal with taxes and
Mhm.
the all the paperwork and the filings that go along with it. But if you have that drive, you have to be, which I feel like a lot of physicians are very self-motivated. And so you have to have that because you don't have anyone telling you what to do or when to do it. You have to just decide it needs done. So you have to have that, and then you have to be willing to, I think, which I would hope most physicians are, but, like, you need to be able to really listen to your patients and know that you are going to be spending a lot more time with your patients, and so you have to have that desire to, like, really dive in deep with patients and their histories, and then outside of that, you just gotta be a pretty good clinician. If you want to start one, what I thought was I was like one of the first pediatricians in Kansas City to have a direct primary care practice, but I was a niche because I do breastfeeding medicine. Also an IBCLC. And so having that as an additional thing, that there's doctors that do like specialize in allergy or something. So you find like your niche and you can really something that you really enjoy, and then that can help set you apart, and it really, like, for me, helped keep my passion going, which I love being a pediatrician. I love doing lactation work, and so it helps keep it sustainable.
Right, right. It's difficult to be siloed, right, today in healthcare without some kind of integration or partnership. Have there been any partners, community partners, or vendors or resources that have helped you along the way?
Direct primary care doctors, other direct primary care doctors, the direct primary care community across the country is phenomenal. I mean, they sent, "Here, hey, here's a checklist of how to actually start your practice in Kansas, of like, here's the link to file your LLC, here's the link to submit it to the Secretary of State, here's the link to do all of this stuff." I am also incredibly lucky to be in Kansas City, which is kind of a very centralized hub for direct primary care. We have several, and they had done a lot of the work with like these labs and imaging negotiation prices. It's called the Midwest Direct Primary Care Alliance. And
Mhm.
Nebraska, Kansas, Missouri, and it's all of us. There's dozens of us now. And when we have a group like that, then we are able to have like a little bit more power for getting these discounts. They also host these meetings where they have things like the most recent one was an orthopedic group that is starting to do a cash pay option for like walk-in fracture clinics and things like that, which, kids always break their arm at a busy part of the day in an ER. And so like they have walk-in fracture clinics. And so they really help with a lot of that, and then a ton of, like, calling them up and they're like, "Hey, I'm out of, urine cups. Do you have any?" "Oh, yeah, 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 swing on by and grab some." So there's so much camaraderie in the direct primary care community that we have just been it has been a godsend. I have no staff. I was completely solo till I hired my second doctor in 2024, and, it has been great.
Wow, that's amazing. I mean, you really have been an incredible role model. I see a book, I see a white paper, I certainly see something in the future, because I can only imagine the trajectory of growth you've had in patients as the word's gotten out, as your outcomes, the benefit, for families, not
Yeah.
only the individual patient, but the impact you're making. I can only imagine you must see a growth trajectory.
Oh, yeah, because I started right out of residency, right? So I wasn't known at all in the community. No one knew who I was. No one wanted to refer to me. No one knew
Wow.
what really direct primary care
Right.
was or what pediatrics was. So I was out every single day, boots on the ground, like networking with people, telling people about what my practice was until it eventually, you hit this bottleneck where enough people tell their friends, because that's how most people find a pediatrician as well. My friend's cousin uses
Yes.
this, and then it eventually hit this, and then it really has, and it's done much better than I would have ever guessed it would be. It's grown to something I'd never imagined that it would be, and I think people just really value having that close relationship with your doctor, that where, they come in and I'm like, "Oh, yeah, how's the new house?" Like, "Oh, are what's the new job like?" And we know them so personally that it creates this extra level of trust and care that I don't think can be matched in a traditional system.
Right. I couldn't agree more. It sounds incredible. In this data-driven world we're in, have you begun to collect that data and really able to demonstrate improvements in growth and development, education for families?
Oh, I haven't, but I would imagine that, like, if I could compare ER visits, something like that,
Hospitalizations or illness.
hospitalizations,
Right,
I would imagine ours is extremely, extremely low. Many reasons. Of one, our patients know when to go to the ER, and so it's not a they aren't going there, not bashing any parents, but like just for a fever or something like that. They call
right.
us, or like they know, oh, hey, we're starting to get this croup cough. Can we go ahead and do some steroids before it gets bad at 2 o'clock in the morning, because that's always when it's bad. And so we're able to prevent a lot of that complication from happening, because we are being able to be proactive and we're telling them what to watch for, when to intervene, and what to intervene with. That I imagine our hospitalization and ER rates are incredibly low.
I'll bet they are. In my world, in home hospice community health, a tremendous benchmark is enabling the patient to remain at home for adults, remain at home, higher quality of life, preventing that revolving
Yeah,
door in and out of the emergency room, technology in the home. For managing, maintaining people living a higher quality of life at home, right? Managing these chronic conditions.
yeah,
I can only imagine what your data is trending at, because it's a better quality of life, more educated families, and you're right, it's earlier intervention versus waiting for the symptoms to show up, and then you have no choice but to seek acute care.
right. And I also would be interested in, like, seeing parents' time off work, days of school missed,
Exactly.
what that measurement would be, because I imagine our parents are taking a lot fewer days
Right,
off and calling in sick a lot less, and our kids are probably in school at better
right.
rates. There's a lot of the question of, like, why would I pay for this and insurance? And it's like, well, if you look at the overall of one ER visit is 6 months of of care, or, the amount of time that you're not taking off of work is also a massive factor.
Right, absolutely. It feels like, you just identified at least 6 data points, and it makes a compelling argument of the value of
Oh,
your
yeah.
model. Absolutely. So, looking beyond today, we know healthcare is constantly evolving, full of headwinds, tailwinds, whether it's policy shifts, staffing pressures, innovations in care delivery. When you think about Bloom Pediatrics 5 or 10 years from now, how do you envision shaping your practice to meet the challenges? What's your vision for this kind of care and experience you want your patients to have?
I've been struggling with this because physically my office is at capacity. Like, there's 4 of us in 1,700 square feet. We are running out of space. We can't add anyone else. But the need is not slowing down. And so my next thought is, like, how can I either coach other people to open one? How can I open additional blooms? How can we shift this to allow for more people to get this level of care? And so that is I think starting now with podcasts like this, where we start teaching people about that there is an alternative way to practice and that this is something that is doable. And it is something that is scary, but it is very doable for other people to do. And then it maybe will be a Bloom somewhere else in Kansas, maybe a Bloom in another state. That is TBD.
That's wonderful. So aspirational. I think probably the sky's the limit of where you can take your practice because it
Yeah.
certainly is an innovative model. And congratulations to you, truly.
Thank you.
So, thank you, Dr. Hughes, for sharing your insight and your vision. It's inspiring to hear how you're shaping pediatrics care in Kansas City and beyond. And I'm sure that listeners have gained valuable perspective on the possibilities of direct primary care. So, thank you very much for your time today. I've learned a lot.
Thank you so much. Thank you, Teresa. I had a good time. Thank you.